Chapter 20, it's about the blood vessels. The blood vessels are arteries, veins, and capillaries. The arteries help to bring the blood away from the heart, while the veins bring back the blood into the heart, and the capillaries act as a bridge that connects the arteries and the veins. In here you can see an artery together with the vein and a nerve. These three structures are referred as neurovascular bundle. So in this other figure that is showing you this micrograph as the previous one with the neurovascular bundle, you can see the vein, the artery, and the nerve. The blood vessels are hollow structures that has walls, and within the walls these blood vessels have layers or tunics. The veins and the arteries, they have three layers. The most internal layer, it is called the tunica interna or tunica intima, and this is the layer that is in close contact with the blood. The tunica interna is made of simple squamous epithelium known as endothelium, and these cells of the simple squamous epithelium are attached to a basement membrane and to loose connective tissue. This layer acts as a selectable permeable barrier. So it's not completely sealed. It allows the passing of cells and chemicals. And this endothelium also can secrete chemicals that stimulates the dilation or constriction of the blood vessel, controlling how much blood flow will pass through these blood vessels. The endothelium regularly will prevent the blood and the platelets from leaving the circulatory system, but it can also help for these cells of the circulatory system and the platelets to adhere to it when this endothelium is damaged to form a blood clot to prevent bleeding. Now, you can have an inflammation around the blood vessels, and the endothelial cells will open up, and then that will induce the leukocytes to migrate into the area where they are needed, in the area of inflammation. The tunica media is the middle layer of the blood vessels, and in this tunica media we have smooth muscle cells and we have collagen and elastic fibers. This middle layer helps to strengthen the blood vessels, preventing the blood vessel from rupturing during the changes in blood pressure. And since we have within these tunica media smooth muscle cells, these smooth muscle cells can contract or can relax, regulating the diameter of the blood vessel. The outer layer of the blood vessels is known as tunica externa or tunica adventitia. This is the most external layer, the one that is in close contact with the neighboring tissues, and within this tunica externa we have loose connective tissue that helps to anchor these blood vessels to nerves and other organs, so it will not be moving freely. Now within this tunica adventitia, we can have small vessels that itself provides provides blood supply to the walls of the larger vessels, and these small vessels are known as vasa vasorum, the ones that are located within the tunica adventitia. This figure shows you the changes of the histology or the tissue within the blood vessels. As the blood vessels are closer to the heart, the three layers that makes up these blood vessels walls, the tunica intima, tunica media, and tunica externa, they are stronger. And at least for the tunica media and the tunica externa, they are thicker. So here on this side you have veins, and on this other side you have arteries, and these are large sized veins, medium-sized veins, and venules, which are kind of small sized veins at some point. And then in here, we have the largest veins that are called conducting, and then the medium-sized veins, which are called distributing, and then we have branches of these distributing arteries that we know as arterioles. And then in between the venules and the arterioles, we have these capillaries that connect the veins to the arteries. So if you see here, within these large veins, we have a thick tunica media, which is this, and a thick tunica externa, which is this. And then we have the vasa vasorum that provides blood supply to these layers. And in here we have the tunica intima or tunica interna, and then the basement membrane. And then as you move down away from the heart, you will be able to see that medium-sized veins, they have valves, which are continuation of the tunica interna. We will see in a few slides what is the function of the valves in the veins. And then as you move towards the venules, this tunica media and the tunica externa, they reduce their thickness. And then you still have this endothelium or the tunica intima. And then the capillaries, they only have one layer, which is endothelium, simple squamous cells, and a basement membrane. And then for the arteries as well, you have increased thickness of the tunica media and the tunica externa when these arteries are close to the heart. And as you move away from the heart, you have less thickness of the tunica media and the tunica externa. Now, the arteries, they have more pressure than veins in general, and they have to have this elastic tissue, which is called the internal elastic lamina and the external elastic lamina, that helps to prevent the rupture of these blood vessels as they are stretching during systole and recoiling during diastole. And then the arterioles as well, they have decreased thickness of the tunica media and the tunica externa. And as you can see here within the arterioles, you don't have as much of this tissue, elastic tissue. And the joining of the veins and the arteries happens within the capillary beds. So we have connections of many capillaries between the arteries and the veins that helps to provide oxygen, nutrients, and carry away wastes from the cells. Another name for the arteries is resistant vessels because their walls are strong and resilient, and the arteries are classified by size. So the largest arteries are known as conducting, large, or elastic. And examples of these will be the largest artery that we have in our body, which is the aorta. Then we have also the common carotids, which are found on the sides of the trachea, subclavian, that are under the clavicle, pulmonary trunk that exits the right ventricle, and the common iliac arteries that we have on the pelvic area. These largest arteries, they have a thick layer of elastic tissue. They have an internal elastic lamina at the border between the tunica interna and the tunica media, and they have this external elastic lamina at the border between the tunica media and the tunica externa. And this is a key point for you to remember, that the elastic fibers in the arteries stretch during systole and recoil during diastole. The key points that I will be mentioning in this video lecture will be mentioned on each slide, not at the end of the presentation, in the slides where we have the key points, okay? Now, the medium-sized arteries are known as distributing or muscular or medium-sized, and they are known as distributing because they help to distribute the blood to specific organs. And usually the arteries will take the name of the organ or the region where they are distributing the blood. So we have examples of this, like the brachial, which distributes the blood into the arm, femoral, which distributes blood into the thigh or the femoral area. We have renal, which distribute the blood into the kidneys, splenic arteries, which distribute the blood into the spleen. And then one characteristic about these medium-sized arteries is that they have a smooth muscle layer that almost makes 3/4 of the wall thickness. That's why they're called muscular. The small-sized arteries, the small-sized arteries are known as resistance arteries, and we have a couple of them. We have the arterioles, which are the smallest arteries, and we have the meta-arterioles. Now the arterioles, they are the ones that control the blood supply into various organs. They have a thicker tunica media in proportion to their lumen than the larger arteries, and they have very little tunica externa. The meta-arterioles are located at specific places. They are located at the short vessels that connects the arterioles to the capillaries. And within these meta-arterioles, we have a smooth muscle cell around them, layer around them, that is called the precapillary sphincter, and that helps to control the amount of blood that is going to pass through a specific area within the capillary veins. If this sphincter, precapillary sphincter, closes, you have reduction of the blood flow through the capillaries, and then that helps to pass blood into a specific region much faster than if these meta-arterioles with their sphincters were open. So this is just to show you the connection between the arteries and the veins. So this is an arterial and this is a venule. This blood vessel that connects the arterial to the venule, it's a capillary. And then in here we have these meta-arterioles with this sphincter that will help when they contract to divert the blood into a different area. Now regularly within these capillaries we will have an end that it is closer to the arterial, that is called the arterial end, and an end that it is closer to the venule, that is going to call the venous end. And of course the side that is closer to the arterioles, the arterial end, is going to be filled with blood that it is oxygenated. That's why you here see the red color. And in this end, the venous end, which is closer to the venule, you have deoxygenated blood, which is depicted with blue color. Some problems that can happen in the walls of the blood vessels are aneurysms. Aneurysms are weaknesses within these layers, the tunica media usually, of the arteries or the heart wall itself. So when you have a weak point in these arteries, you have this change in the blood pressure that is going to bulge as a sac each time that you have contraction of your heart, so during systole. And if the pressure is so high, this aneurysm can rupture and then you can have escape of blood. And depending on the artery where you have this aneurysm is going to be the consequences. Some common places for having aneurysms will be the abdominal aorta. Another one can be the renal arteries or in the arterial circle at the base of the brain. Usually these are important places, but the most important place is the abdominal aorta because that's where we have a lot of pressure. And it's very likely that when someone has an aneurysm in the abdominal aorta and rupture, this person will bleed to death. This is a CT scan of an aneurysm in the abdominal aorta. So here we have the lumbar area, and then this bulging is the aortic aneurysm. Our aortic aneurysm hardly give signs and symptoms, so only give symptoms when they rupture, and kind of the symptoms when you have a hemorrhage is very sudden drop in the blood pressure, so the person will fall into hypovolemic shock and the person very likely will die. Within the blood vessels, we have some receptors that helps to detect changes in the blood pressure or changes in the chemical components in our blood. We have them at specific places, like in the carotid artery, in the carotid sinuses, within the internal carotid artery. And they help to monitor the blood pressure, and when you have changes in the blood pressure, you will send a signal into the brain through the cranial nerve number 9 or glossopharyngeal, and then you will elicit a response that is going to be called the baroreflex. Within the carotid artery, we also have these chemoreceptors that are oval shaped, and they are called oval bodies, and they are located at the area where the common carotids split or branch. These chemoreceptors help to detect changes in the chemistry of the blood, and then they also transmit the signals into the brain using cranial nerve number 9 or glossopharyngeal nerve, and then they send this signal into the brainstem or the respiratory centers, so you can adjust your respiratory rate to compensate for changes in the concentration of hydrogen ions in our body, which is known as pH, and also changes in the amount of CO2 and oxygen. For instance, if you have increase in CO2 in your blood, you exhale more, so you will breathe faster. Now, we also have chemoreceptors in the aorta, in the aortic arch. These are between 1 to 3 aortic bodies, and they have the same function as the carotid bodies, but instead of sending the signal to the brain using the glossopharyngeal nerve, they send the signal into the brain using cranial nerve number 10 or vagus nerve. Now, these aortic and carotid baroreceptors, they also detect changes in the blood pressure. So, whenever you have a drop in the blood pressure, both aortic and carotid baroreceptors slow the action potential discharge. This slowing in the action potential discharge is going to increase the heart rate and the stroke volume, so you can increase the blood pressure to compensate for this low blood pressure. So this is another key point that you need to understand, that low blood pressure will decrease the discharging of the aortic and carotid baroreceptors, and this will have a response, which will be increasing the heart rate and increasing the stroke volume to increase the blood pressure so you don't faint. So this is the location then of the baroreceptors and chemoreceptors. So in here, in the aortic arch, we have these baroreceptors, and then we have these chemoreceptors that are known as aortic bodies. And then if you go up following this artery, which is the right common carotid, you will reach here this carotid sinus, which is located within this artery that is known as the internal carotid artery, that helps to detect changes in the blood pressure. And then in here we have the carotid body, which has chemoreceptors, and these chemoreceptors again detect changes in pH, levels of CO2, and levels of oxygen. So just to show you that the carotid body and aortic body chemoreceptors, they have these connections through the vagus nerve and glossopharyngeal that sends signals to the brain to see or to tell to our body what is going on. Now let's talk about the capillaries. The capillaries are exchange vessels. So these are known as exchange vessels because you have an exchange of gases, CO2, oxygen, nutrients, wastes, uh, and hormones passing between the blood and the tissue fluid. The capillaries, the walls are made out of a single layer, the tunica intima, and this single layer again is made of simple squamous epithelium, also known as endothelium. And the capillaries are found everywhere in the body in the capillary beds, with the exception of the tendons, ligaments, epithelia, cornea, cartilage, and lens of the eye. We have different types of capillaries depending on how permeable they are. So we have continuous capillaries, which are not as permeable as the fenestrated capillaries, and we have freely permeable capillaries that are known as sinusoids. So let's talk about the characteristics of the continuous capillaries. So these are the most common type of capillaries that we have in the body, and their endothelial cells are connected to each other using tight junctions. And within these capillaries, we have passage of solutes like glucose and other nutrients. And we have within these capillaries some cells that wrap around that are known as pericytes. And they have this contractile protein as muscle that helps to contract and regulate the blood flow. The fenestrated capillaries are located within the kidneys and the small intestines, and they have a great amount of absorption and filtration happening through these capillaries. And the endothelial cells within these fenestrated capillaries, they have holes that are known as filtration pores or fenestrations. And they have very little glycoprotein layer. And these fenestrations allow the passage of only small molecules. So they are selective in size of what they can pass through these fenestrated capillaries. The third type of capillaries are the sinusoids or discontinuous capillaries, and they are located in very few places like the liver, the bone marrow, and the spleen. Within these sinusoids, we have large fenestrations or openings. And within these large fenestrations, you have the passage of large proteins like albumin, clotting factors, and new blood cells. So when you produce your blood cells in the bone marrow, they enter into the circulation using the sinusoids. So this is a cross-section of a continuous capillary. This is the endothelium. So the endothelial cells connected by tight junctions, and in here you have something that is called the intercellular cleft. This is the nucleus of the endothelial cell. You have mitochondria and organelles as any other cell. This will be the lumen with an erythrocyte, and then this is a pericyte. Now the side-to-side diameter of these capillaries is usually 4 micrometers. And if you remember, the side-to-side diameter of a red blood cell is 8 micrometers. So it's double the size of the capillaries. Now, because of the red blood cells having this biconcave shape and this disc shape, they can squeeze through these capillaries without so much problem. And then these pericytes contract to reduce the diameter of the capillaries when necessary. And here is another tight junction between these endothelial cells. Now, these endothelial cells can separate when they are needed so that you can allow the escape of cells, blood cells, into the area where they might be needed. This is a cross section and an electron micrograph of the fenestrated capillaries. So the fenestrated capillaries, they have as well endothelial cells, but within these endothelial cells you have these fenestrations or pores. And if you see in this electron micrograph or microscopy, you can see these little pores or fenestrations. These are the sinusoids. So this is a cross and longitudinal section of a sinusoid. So within these sinusoids, we have these endothelial cells that are separated by these great fenestrations. So these are the hepatocytes that surrounds this sinusoid. These are the sinusoid cells inside this layer of hepatocytes or liver cells. And then red blood cells, proteins, clotting factors can exit through these sinusoids. So the capillaries, they form groups of 10 to 100 and they interconnect. These are known as capillary beds. And usually the capillary beds are supplied by a single arteriole or meta-arteriole. And at the end of these distal capillaries, of these capillary beds, you have a transition to venous, or you have a thoroughfare channel or meta-arteriole. And then usually our capillaries are not fully open all the time, so at a given time 3/4 of our capillaries are shut down. And only when you have an active tissue you can open up these capillaries so you can have more oxygenation and nutrients coming into these cells. Now within these capillary beds we have these precapillary sphincters or smooth muscle cells that can contract or relax to prevent blood flow into these capillary beds or to allow more blood flow to happen within these capillary beds. And again, you already saw this. So these are the capillary beds. And then we have these sphincters that when they constrict, they prevent blood going into these small capillaries, and then they allow the passage of blood directly from the arterioles into the venules. Now let's talk about characteristics of the veins. So the veins, they have a greater volume capacity when in compared to the arteries. They have a thinner wall. These walls are not as strong as the ones for the arteries, and they have less muscle, smooth muscle, and elastic tissue. The arteries, they collapse when they are empty and they can expand really easily, and they usually have a steady blood flow. These arteries, they will merge, these veins will merge and they form larger veins, and within the arteries, within the veins, we don't have as much pressure as in the arteries. The average of blood pressure that we have in the veins is 10 millimeters of mercury, while the average pressure within the arteries will be 90 millimeters of mercury. So this is the distribution of blood within the circulatory system in a resting adult. So the arteries, because they hold around 64% of the blood of our body, they are known as capacitance vessels. And then very few blood is located within the arteries, 15%, 5% within the capillaries, 7% within the heart, and 9% within the pulmonary circuit. And in total, we have 84% within the systemic circuit. The smallest veins are known as postcapillary venules or venules. And these venules, they have more pores than the capillaries. So you can have many fluid exchange with the surrounding tissues using the venules. And the venules, they have a tunica interna with some cells that are called the fibroblast. And within the venules, we don't have muscle fibers. Now, because of this porosity of these venules, most of the leukocytes emigrate from the bloodstream through the venule walls. As the venules move, or as you move towards the heart, the venules will become larger, and they will be called the muscular venules. Muscular venules, they can have up to 1 millimeter in diameter, and they can have 1 or 2 layers of smooth muscle cells in the tunica media, and they have a very thin tunica externa. These muscular venules can merge, and then they can form, or they will form, medium-sized veins. These medium-sized veins, they will have a diameter of 1 centimeter or 10 millimeters, and within these medium vein walls, we have a thin tunica media and a thick tunica externa. And the tunica interna in the medium veins, they will have venous valves, the ones that we have in the legs. The medium-sized veins in our legs, they will have venous valves, and these venous valves help to bring the blood from the legs towards the heart. And sometimes these valves, the venous valves, are very flexible, so they are very elastic, and they failure to act as a valve, and then you have the formation of what we call varicose veins. Now, these medium-sized veins are usually surrounded by the muscles in our legs. And these muscles in our legs will contract, and they will help to squeeze the blood out from the veins, bringing up against gravity towards the heart. Other types of veins that we have are what we call the venous sinuses. These venous sinuses are located within the brain or within the heart, the coronary sinus that you already saw in the previous chapter. And the ones that are located within the brain are called the dural venous sinuses. Now, these veins, they have very thin walls, they have a large lumen or large diameter, and they don't have a smooth muscle. And because they don't have a smooth muscle, they cannot contract. So they are not capable of having a vasomotor response. Now, the medium-sized veins, they will merge, and they will form large-sized veins that have a diameter larger than 1 centimeter or 10 millimeters. And within these large veins, some of them, they will have smooth muscle in all the 3 tunics. And the tunica media, it is thin, and it has a moderate amount of smooth muscle, while the tunica externa, it is the thickest layer, and it will have longitudinal bundles of smooth muscle. Examples of these large veins will be the vena cava, the pulmonary veins, internal jugular veins that are located on the sides of the trachea, and the renal veins. So the veins, in general, they carry oxygen-rich blood. CO2-rich blood. So the veins, they carry CO2-rich blood in general, with the exception of the pulmonary veins. Remember, the pulmonary veins, they will bring the blood back from the lungs into the heart. So the oxygenated blood from the lungs into the heart moves through the pulmonary vein. So this will be the only oxygenated blood that goes through a vein. And the arteries have the opposite. So the arteries have oxygenated blood only, with the exception of the pulmonary trunk and the pulmonary arteries, which carry CO2-rich blood. Now, the veins then return the blood into the heart, and exercise helps to increase this blood return in many ways. So when the heart beats faster and harder, increases the cardiac output and the blood pressure. This will help for the vessels within the skeletal muscles, the lungs, and the heart to dilate and increase the blood flow. And then you will increase your respiratory rate and the pump action of the thoracic cavity, and you will have increased skeletal muscle pump that will squeeze the blood back into the heart coming from the veins. The respiratory or thoracic pump helps to bring blood into the heart because inhalation, when you expand your thoracic cavity and you inhale, you decrease the thoracic pressure, and then you increase your abdominal pressure that forces the blood towards the heart. And you have changes in the venous pressure when you're inhaling and when you're exhaling. So you have 2 millimeters of mercury when you are inhaling and 6 millimeters of mercury when you're exhaling. So since in inhalation you have less central venous pressure, you will allow the blood to flow much faster during inhalation because there is a greater difference or gradient between the arterial blood pressure and the venous blood pressure. So there is less resistance then from the pressure in the veins that allows the blood to return much faster. And then you have the cardiac suction of the expanding atrial space during inhalation. Along with the thoracic pump, you have the skeletal muscle pump that helps to bring the blood toward the heart. So when you have contraction of your calf muscles, in this case, you will squeeze the blood that was previously found in this vein, and the blood by gravity that tends to go down, it will go up because you contract your muscles. And then when you relax your muscles, the blood will tend to go down, but it will stay up to a certain level because these are the venous valves that prevents the blood from going into the heel, if you don't have, of course, varicose veins. So this is another key point. So the venous valves and blood return. So the valves helps to channel the blood toward the heart. That's one key point. Second key point that you have in this slide is that the blood moves forward in the veins because you have valves in the veins that prevents backward flow of blood and also because the pressure in the veins is lower than the arteries. Remember, the usual blood pressure in the veins is 10 millimeters of mercury, and the main arterial pressure in the veins is 90. So there is a difference of 80 millimeters of mercury. So the blood will always flow from the arteries into the veins. And then another point of why the blood will move forward in the veins is because you have muscular compression and then you have the respiratory pump. Now the blood follows certain circulatory routes, and this is another key point for you to understand. So when you have blood entering from the systemic circulation, it will follow a specific sequence. So the blood enters from the systemic circulation following this sequence. It goes from the vena cava, superior and inferior, brings blood into the right atrium. The blood from the right atrium will go into the right ventricle, which will go into the pulmonary trunk, and then you oxygenate the blood. You will return it into the heart using the pulmonary veins, and the pulmonary veins will drain the blood into the left atrium, and then from there the left atrium will bring the blood into the left ventricle and then into the aorta. And blood passes through only one network of capillaries from the time it leaves the heart until the time it returns. So the simplest pathway to follow from the aorta going into tissues is going into the capillary beds, only one, or going into two capillary beds that we know as portal system when you have connection between two capillary beds, or it can go into what we call arteriovenous anastomosis, which is this. So you have a capillary bed, as you can see here, but your artery and your veins are connected. When you have a shunt or a connection, it is called anastomosis. And you can have arterial anastomosis, in this case, in which you have two arteries connecting through blood vessels in here, or you can have venous anastomosis, in which you have veins connected through blood vessels in here. So these are the variations in the circulatory pathways: capillary beds, portal system, arteriovenous anastomosis, arterial anastomosis, or venous anastomosis, or connections or shunts. So the portal system will allow the blood flow from two consecutive capillary networks before returning into the heart. Examples where we have these anastomosis or these portal systems will be between the hypothalamus and the anterior pituitary gland in the brain. We also have within the kidneys or between the intestines to the liver. The definition of anastomosis will be the convergence of two vessels other than capillaries. And if you have a connection then between an artery and a vein, you will have what we call a shunt or arteriovenous anastomosis. So in this case, the artery will flow directly into the vein, bypassing the capillaries. These at some point are good because let's say that someone has a hemorrhage in a particular area of the body, and this hemorrhage is massive. This person will need blood going into the brain, into the heart, into the kidneys, because these are the most important organs in our body. And when you shut down these capillaries, when you bypass them, you allow the blood going directly from arteries into the veins to maintain a specific blood pressure so that the person can receive more blood supply into the brain, into the heart, or into the vein, or into the kidneys. Now, the venous anastomosis happens too, so the connection between two veins. These are the most common types and of anastomosis, and they help to also increase the blood pressure. Now, the arterial anastomosis is where two arteries will merge, and this will happen when you are finding an alternative route of blood supply to a tissue. Example of arterial anastomosis will be the coronary circulation and many of the arteries that are located around the joints. So that was the part that talks about the structural and anatomical distribution of the arteries and the veins. Now let's talk about the physiology of blood pressure, blood resistance, and blood flow. So when you are providing blood supply into a tissue, you can express this blood supply in terms of blood flow and perfusion. Blood flow will be the specific volume per minute that an organ or a tissue receives at a given time. Perfusion will go a little bit beyond. It not only deals with a specific amount of volume given to a tissue per minute of time, but also per gram of the tissue. So certain organs, they receive more perfusion per gram than others. So you can have an organ that is not very active, or a tissue that is not very active, like the adipose tissue, and you can have an organ or a tissue that is very active, like in the case of the brain, because the brain tissue is more active than the adipose tissue. of course you expect to have more perfusion or more flow of blood going into the brain than going into the adipose tissue at a given time. And during rest, the total flow of blood is quite constant to the many organs that we have in the body. And the cardiac output, which is around 5.25 liters per minute, will provide the blood supply at a constant rate to the different organs in our body. And within this cardiac output, you distribute more amount to the tissues that are active more than others. So blood pressure, resistance, and blood flow are important because they help to deliver the nutrients and oxygen and remove metabolic wastes of the cells whenever they have the need to do so. And in order to study this, we have hemodynamics. And in hemodynamics, you use physical principles to understand the blood flow. So in this formula that you can see here, you have that blood flow is directly proportional to a change in pressure and inversely proportional to the resistance. So what it means is that when you have more difference or gradient in the blood pressure, you will have more flow. And when you have more resistance, you have less blood flow. It's like when you have more resistance, you can compare it when you are squeezing the part of a hose, a garden hose. The more that you squeeze, the more resistance that you provide to this garden hose. When this garden hose is open, the less water that you expect to exit from that end. So what is blood pressure? Blood pressure is the force that the blood exerts against a vessel wall. Blood pressure is measured by an sphygmomanometer or barometer at usually the brachial artery that is located in the anterior part of our elbow. We use, when we are using an analog sphygmomanometer, we use an stethoscope that we put on the surface of the antecubital area, and we hear these sounds that are called the sounds of Korotov, K-O-R-O-T-O-F-F. So we listen to these sounds as we compress this area proximal to the antecubital area, the brachium, with a cuff. As we inflate this cuff, we compress this artery, the brachial artery, and as the blood is flowing, when you deflate this cuff, you will hear a very loud sound. The first loud sound that you hear, that will be the systolic pressure. And then the last sound, the weakest sound that you will hear, that will be the diastolic pressure. So the systolic pressure will correspond to ventricular systole, and usually in an adult who's not hypertensive, it will be 120 millimeters of mercury. Now the diastolic pressure will be corresponding to ventricular diastole, and this will be usually like around 75 or 80 millimeters of mercury in someone who doesn't have hypertension. Now, the difference between systolic and diastolic pressure, the difference between 120 over 80 is known as pulse pressure. And this helps to measure the driving force of circulation, and this can vary. And the pulse pressure, since it can vary throughout the day, you can calculate what we call the mean arterial pressure, which will be the average pressure that one can obtain by taking measurements of the blood pressure during several intervals of time throughout the day. So MAP, or mean arterial blood pressure, can be calculated adding systolic pressure plus 1/3 of the pulse pressure. So let's say that someone has uh, a pressure of, let's see, 120 over 90. So if you add to the diastolic uh, pressure, which was 90, 1/3 of the pulse pressure, which was 30, because that's the difference between 120 over 90, you add 10, then you will have a mean arterial pressure of 100, okay, millimeters of mercury. And then this pressure is taken because this can influence the risk level of someone having uh, excess of fluid within the outside of the tissues, which we call edema, or it can influence the chances of someone fainting or having atherosclerosis, kidney failure, aneurysm, etc. So having high blood pressure is known as hypertension, and is having a chronic resting blood pressure over 140 over 90. If someone has high blood pressure, this can damage the tissues in our body, like our arteries. Also, it can cause aneurysms, or it can promote the formation of plaques inside the blood vessels, or atherosclerosis. Now, having hypotension is having chronic low blood pressure, and this is caused by having blood loss or dehydration or anemia. Now, there is no a specific number for hypotension because someone actually can have low blood pressure reading but without fainting, and unless the person has signs and symptoms, that person can be said to have hypotension. What can be the signs and symptoms? Feeling dizzy or fainting. What are the factors that determines the blood pressure? Well, would be cardiac output, or the amount of blood that we pump per minute, the blood volume, and the resistance to the blood flow. So blood volume is usually regulated by our kidneys. And as we age, we have the tendency to have increased blood pressure. Why? Because our elastic tissue in our arteries is not as elastic anymore. It disappears as well. And then we develop what we call arteriosclerosis, which is a stiffening of our arteries. And then we also develop atherosclerosis, which is the building up of fat within, or plaque within the blood vessels. So in this diagram, it shows you the changes that happens within the different blood vessels when they are closer or away from the heart. So in the aorta, you have fluctuation of pressure between 120 over 80. As you move into large arteries, this fluctuation of the blood pressure decreases, like around, let's say, between 90 to 70 millimeters of mercury, and you keep on going. So systolic blood pressure and diastolic blood pressure creates changes in pressure within the arteries. And as the arteries move away from the heart, like in the case of the arterioles, these changes in blood pressure decreases. And when you reach the capillaries, the venules, the small veins, etc., this fluctuation in blood pressure doesn't happen. And the farther away from the heart, like in the case of these small veins, large veins, etc., the decrease of the blood pressure. Peripheral resistance is the most important factor that influences the blood pressure. So this peripheral resistance refers to the opposition or the resistance to blood flow that the blood encounters in vessels away from the heart. The arterioles will be the blood vessels where we have the greater resistance. Now, the resistance, it is in fact influenced by factors like the viscosity of the blood, the length of the blood vessel, and the radius of the blood vessel. The viscosity of the blood, the thickness, it is influenced by the number of red blood cells, the amount of albumin that we will have. When you have increased number of red blood cells, like in polycythemia, you have increased viscosity of the blood. When you have hypoproteinemia, or when you have low low number of red blood cells, like in anemia, you have decreased viscosity of the blood. And when the blood is viscous, the blood flow is slow. Now, the vessel length influences, but at some point, our blood vessels, once we reach adult life, they don't change in length. So that is the least common factor that influences our blood pressure. Now, the radius, it is the most powerful influence, because when you decrease the diameter of the blood vessel, under the influence of several things, like for instance the sympathetic system, you will increase the blood pressure. Is what I told you before. When you squeeze a part of a garden hose that is open, you increase the resistance, and you expect less water coming out from the end of that garden hose. Now, the vessel radius is influenced by the sympathetic system. So when you have the sympathetic system active, you produce vasoconstriction, because we have receptors within the smooth muscle cells of the tunica media that respond to adrenaline or noradrenaline that are released by the sympathetic system nerves, and they will produce the constriction or reduction of the diameter of these blood vessels. Now, when you have less activation of the sympathetic system, you have vasodilation, because you have relaxation of the smooth muscle. And the blood flow, as it shows here in this formula, is directly proportional to the fourth power of the radius. So a small change in the radius of the blood vessel can increase your resistance for a greater extent. And this is just to show you what happens when you decrease the blood vessel radius. So when you have a normal radius in your blood vessel, you have a good laminar flow within this blood vessel. Now, this laminar flow is greater in the center of the blood vessel, because the blood, it is not moving against friction as the one that is happening at the edge of these walls. So when you have friction, you reduce the flow, as you can see here. And then when you reduce this diameter or this radius, you will decrease the flow, because you increase friction. So in peripheral resistance, from the aorta to the capillaries, the velocity or the speed decreases, because there is a greater distance or more friction that decreases the speed. And as you move away from the heart, you will have blood vessels that have a smaller diameter, like the capillaries and the arterioles. And the arterioles, they have this greater resistance because they have a wall that has smooth muscle cells around. So these smooth muscle cells, they respond greatly to the sympathetic system. And also, the third reason why the blood flow decreases from the aorta into the capillaries is because when you are farther away from the heart, you have a greater number of blood vessels that forms a greater cross-sectional area with a greater resistance. And then when you move back from the capillaries into the largest veins, like the vena cava, you will have the corresponding increase in the blood flow because the larger veins will provide less resistance or less friction than the capillaries. Now, the arterioles, the ones that are more importantly involved in peripheral resistance, they will outnumber any type of artery. So they provide more control points for blood pressure than any other blood vessel. And they have more muscle cells in proportion to their diameter. So they are more likely to change their radius than other arteries. So that's why they produce half of the total peripheral resistance in comparison to the rest of the blood vessels. Now, another way that you can control the blood pressure and blood flow is by vasomotion. And we have these controls of vasomotion or vasomotor control that are local, neural, and hormonal. So let's look at each of them. So the local control of the movement of the blood vessels is known as autoregulation. And in autoregulation, what you have is the activity of the cells that produces certain wastes or chemicals that stimulates vasodilation to increase perfusion. For instance, when you start doing exercise, you start producing more CO2 with your cells and you increase the demand for oxygen. So that it is detected by the cells, the demand of oxygen, and then the increase of CO2 is also detected, and that will stimulate the endothelial cells of this muscle that you are working out, so you can increase the diameter of the blood vessels so you can increase perfusion. Once you remove that CO2, your blood vessels will return to the normal diameter or when you stop doing exercise. Some of the chemicals that are released by the cells that are in charge of local control will be histamine, bradykinin, prostaglandins that increases the diameter of the blood vessels, so they stimulate vasodilation, and also prostacyclin and nitric oxide. Now we also have what we call reactive hyperemia. This is part of the local control, in which if you cut the blood supply off and then you restore it, your flow will increase above normal. Along with that, you have the formation of growth factors that we call angiogenic factors. These angiogenic factors will produce this formation of new blood vessels that is called angiogenesis. So it occurs in the regrowth, for instance, of the uterine lining when we have our menses during reproductive life. Also, if someone, for instance, have a coronary artery obstruction, these cells that are hypoxic will release these angiogenic factors so you can grow new blood vessels. But this growth of the new blood vessels is not going to be kind of sufficient to prevent the hypoxia that happens during coronary artery obstruction. So it's not a perfect remedy. And when you exercise your muscles or when someone has cancer, cancer cells can secrete angiogenic factors so that they can attract blood vessels and then they can receive the nutrients. And angiogenic factors are controlled from forming by several growth factors and inhibitors. The neural control of the blood flow can happen within the CNS and the ANS. And within the medulla oblongata, above the spinal cord, we have the vasomotor centers that are part of the sympathetic system, the ANS, that helps to control the diameter of the blood vessels. So, depending on how much activity you have of the sympathetic system, is whether you will have vasodilation or vasoconstriction. Now, parasympathetic system doesn't influence the diameter of our blood vessels, only sympathetic system. Now, the sympathetic system works with reflexes, baroreflexes, chemoreflexes, and medullary ischemic reflexes. So the baroreflex will detect changes in blood pressure. So when you have a drop in the blood pressure or an increase in the blood pressure, you can have more or less activation of the sympathetic system. And the receptors that detect the blood pressure changes sends the signal into the brainstem using the glossopharyngeal nerve. This will result in inhibition of the sympathetic system when you have increase in the blood pressure, or activation of the sympathetic system when you have a decrease in the blood pressure, and you have excitation of the vagus nerves to slow the heart rate and reduce the blood pressure. So indirectly, you can reduce the blood pressure by decreasing the heart rate when you activate the vagus nerve. Now, the baroreflex will just make these short-term changes into the blood pressure. It will help to adjust the blood pressure when you have a rapid change in posture, but it won't be helpful to correct chronic hypertension. And after 2 days or less, they adjust the blood pressure to a certain point. So, negative feedback helps to control the blood pressure. And you can see it in here. So, when you have reduced blood pressure, you will activate these signal centers within the, these vasomotor centers within the medulla oblongata that will help to increase heart rate and the contractility of the heart, so you can increase the blood pressure. So when you have increased blood pressure, your arteries become stretched, your baroreceptors increase the firing rate, and you will inhibit your vasomotor center, but you stimulate your cardioinhibitory center. So that will increase the vagus nerve, reduces the heart rate, and reduces the blood pressure. And when you inhibit your vasomotor center, you will reduce the sympathetic tone, so you have less vasoconstriction, and you have vasodilation, and you increase your blood pressure. Chemoreflex is part of the neural control of the blood pressure, and it will provide a response to changes in the chemistry of our blood, especially when you have changes in the pH or concentration of hydrogen ions, and also in the concentrations of oxygen and CO2. Again, the chemoreceptors that we have them within the aorta and within the carotid bodies. So when you have these changes in the chemistry of our blood, you can adjust respiration as a primary role, and you can change the diameter of the blood vessels or vasomotion as a secondary role. So examples of what happened when you have hypoxemia, hypercapnia, or increase of CO2 and acidosis. You will stimulate your chemoreceptors, and then you will send a signal to the vasomotor centers that will cause vasoconstriction in many of your blood vessels within your body. You will increase the blood pressure, which will increase the perfusion or the distribution of blood within the lungs. You will increase gas exchange. You will stimulate respiratory rate, so you can get rid of CO2. Another mechanism of neurocontrol is what we call the medullary ischemic reflex. So when you have a drop in the blood pressure, you will have a drop in the blood flow to the brain. so your brain will receive less blood flow. And we have within the medulla oblongata receptors that can detect its own blood supply. When you have reduced blood supply, you will activate reflexes that are going to correct the situation. So you will activate your cardiac and vasomotor centers, and then you will send a sympathetic nerve signal into the heart and the blood vessels so you can increase the contractility of the heart and the heart rate, and also you will produce vasoconstriction so you can have more blood pressure, so increase blood pressure, and then you can restore the blood flow into the brain. Now, other things that can produce this activation of these vasomotor centers is having a stress, being anger, or both of them. So, sympathetic activation increases the blood pressure because you have vasoconstriction. And when you are exercising, your sympathetic system becomes more active and increases the blood pressure, and also will increase your heart rate and contractility of the heart. This is one of the things that we will see in the cardiovascular system lab exercise. And when you are resting, your blood pressure is usually between 120/80, and both sympathetic and parasympathetic systems are active, making this to happen, to have this normal blood pressure. But the parasympathetic system, remember, is part of the rest and digest system, so this will be a more predominant system when you are at rest than the sympathetic system. And when you start exercising, your sympathetic system will predominate over the parasympathetic system, so it will increase your heart rate, your contractility of the heart, and your blood pressure. The other mechanism for blood flow control is the hormonal control. So hormones influence blood pressure because they can be vasoactive, or they can control the amount of the amount of water within the blood. So hormones like angiotensin II can influence blood pressure. For instance, angiotensin II can increase blood pressure because it's a vasoconstrictor. This angiotensin II can also increase the absorption of sodium and water by the kidneys, so it will increase blood pressure and blood volume. Another hormone is ANP, or atrial natriuretic peptide. This will be released by the right atrium cells. When you have an increase in the blood returning to the right atrium, your right atrium cells become active, secretes ANP, and then you will increase the excretion of sodium and water. So you will reduce the blood pressure because sodium is usually followed by water. Another hormone that controls the blood pressure is ADH, or antidiuretic hormone. This ADH will increase blood volume and blood pressure because it helps to absorb sodium and water within the kidneys. Now, when you have high concentration of ADH, you will have an abnormal response that it is known as vasoconstriction. This is why this hormone is also known as vasopressin. Epinephrine and norepinephrine are a couple of hormones that are secreted by the adrenal medulla and also by the sympathetic nerve cells. So, whenever you have epinephrine and norepinephrine because you are stressed or you are scared, you will increase your blood pressure. This epinephrine and norepinephrine binds to receptors within the blood vessels that increases the constriction in the case when epinephrine or epinephrine binds to the alpha adrenergic receptors in most of the blood vessels and will improve the blood flow to the muscle cells, cardiac muscle cells, blood vessels, circulation, because you have the binding of this into the beta adrenergic receptors, and also increases the contractility of the heart because beta adrenergic receptors increases the contractility of the heart. So the blood flow in response to needs according to this diagram. So when you are at rest, you have eaten, you are absorbing nutrients. So you have blood flow going more into the digestive system to absorb rather than into your muscles. Now, when you start exercising, you will reduce the blood flow into the digestive system because it's not needed, but you increase your blood flow into your muscles because you need to have energy so you can contract your muscles. So this is a pie chart showing you or a couple of pie charts showing you the blood flow comparison between rest and moderate exercise. So during rest, you have a cardiac output of 5 liters per minute, and you distribute proportionally this blood flow along the different systems or organs. So 20% goes into the muscles, 27% into the digestive system, 22 or 25% into the kidneys, 14% into the brain, etc. Now, when you have moderate exercise, you can increase your cardiac output up to 17.5 liters per minute, and 71.4 or 12.5 liters per minute can go into your muscles. And then you reduce your digestive system perfusion from 27% to 3.4, etc. Now let's talk about the physiology of the capillaries. So the capillaries are known as exchange vessels, and these exchange vessels are constantly exchanging oxygen, nutrients, CO2, uh, water, glucose, etc. And they do so because they are subject to different mechanisms that allows them to make this exchange. One of these will be the action of chemicals. Through the action of chemicals, the chemicals can pass from the capillary into the cells that are surrounding them. And these chemicals will pass through these intercellular clefts between the endothelial cells or between the fenestrations if the capillaries are fenestrated. Any exchange that happens within the capillaries happens by 4 mechanisms. Through diffusion, in which the molecules will move from an area of high concentration to lower concentration. Through transcytosis, in which the molecules move across the cells. Through filtration, in which you have this great pressure at the arterial end that allows the exit of fluids through this end, and through reabsorption, in which you have decreased pressure of the capillaries at the venous end that allows the reabsorption of these substances within this venous end. So these are the routes then for the capillary fluid exchange through these filtration pores, through diffusion in these endothelial cells without using any type of vesicles like in the case of transcytosis, or through the spaces in between the cells that are known as intercellular clefts. So for filtration and reabsorption, these are the couple of mechanisms where we have the greatest exchange in the capillaries. So in this case, fluid filters out of the arterial end, and then they get reabsorbed or re-enter through the venous end. This filtration and reabsorption allows the delivery of materials to the cells like oxygen, nutrients, hormones, and remove metabolic wastes like urea, like CO2, etc. This is another key point that it is important for you to understand and to make notes of. That within these capillaries we have two opposing forces that allows this filtration and reabsorption to happen. So the blood hydrostatic pressure drives fluid out of the capillary. So this is filtration. Blood hydrostatic pressure drives the fluid out of the capillaries. And colloid osmotic pressure draws fluid into the capillary. So this is reabsorption. So hydrostatic pressure is the pressure of water. That's why it's called hydrostatic, because hydros means water. And osmotic pressure is the pressure of proteins inside the capillaries. So hydrostatic pressure is the physical force exerted against the surface by a liquid. In this case will be water. And the capillaries reabsorb more, like 85% of the fluid that they filter. And they keep 15% of that fluid within the extracellular space, the area where they have just filtered the fluid. So 15% that it is left in the extracellular fluid will be absorbed by the lymphatic system and return into the blood. So filtration happens at the arterial end and reabsorption at the venous end. And with some variations, like in the case of the glomeruli, which only is devoted to filtration, and the alveolar capillaries that only absorbs. And when you have increased physical activity or trauma, you have increased filtration. So that's why after trauma you have a little bit of edema or inflammation. So this diagram shows you the difference in these forces that allows the filtration and the reabsorption to happen. So here we have an arterial and here we have a venule, and this will be the capillary. So this will be the arterial end and this will be the venous end. So the hydrostatic pressure within the arterial end will be 33 millimeters of mercury. And then the oncotic pressure or osmotic pressure will be 20. So 33 that moves the fluid out, hydrostatic pressure, and 20 that moves the fluid in, the osmotic pressure. So you have a gradient or a difference of 13. Because of that, you have more fluid moving out or filtrating than what you absorb. And then as you move from the arterial end into the venous end, you will have less water within your capillaries. So you increase the concentration or density of your proteins. So your osmotic pressure or oncotic pressure is going to be greater 20 than 13, the hydrostatic pressure. So you have a 7 difference or net filtration or reabsorption pressure. So in this case it's going to be 7 reabsorption pressure of difference. So more fluid will move in or be reabsorbed than what it goes out. And at some point there is a middle point in here between the arterial and the venous end where the pressure of absorption and filtration is going to be neutral, so equal. So you won't have absorption, neither filtration. So capillaries usually reabsorb most of the fluid that they filter, with certain exceptions, like in the case of the kidney capillaries, the glomeruli that don't reabsorb, or in the alveoli that usually absorb more than filtrate. And then when the absorption is not as good as the filtration, you can have accumulation of fluid that we know as edema. And edema can happen because of several causes, including that you have increased filtration, like when you have kidney failure, when you have release of chemicals like histamine, when we become old, we filtrate more than what we absorb, and when you have poor venous return. Another cause for edema is when you have reduced capillary absorption, like when someone has low levels of proteins in their blood, like hypoproteinemia, when someone has liver disease that doesn't produce as many proteins, or when someone doesn't ingest as much proteins, okay? Or if your lymphatics, the ones that pick up that 15% that wasn't absorbed, the fluid that wasn't absorbed, get obstructed, uh, because your lymph nodes were removed, or your lymphatic vessels were removed, or they are inflamed, you have poor reabsorption. Okay, now let's talk about an important organ that receives blood supply, so the brain. The total blood flow to the brain can fluctuate less than any other organ. Why? Because the brain is constantly active. So it always have to have a constant supply of blood. Usually is 700 milliliters per minute. And when you decrease this blood flow into the brain for just a few seconds, it can cause unconsciousness. If someone get deprived of blood going into the brain for 5 minutes, the neurons will have severe damage, and this damage is going to be permanent. So from time to time, you will have a change of blood flow going into different areas of the brain. So when you're studying, you're shifting your blood supply into the areas of the brain that deals with learning or storing memory. Now, the brain can regulate its own blood supply to match the changes in the blood pressure and chemistry. So, the cerebral arteries, the ones that provide blood supply to the brain, can dilate when someone has a drop in the blood pressure, because you always have to have the constant blood supply into the brain. And if someone has increase in blood pressure, the opposite is going to happen. So you will constrict your cerebral arteries so you don't receive as much blood. And things that stimulate the changes in the diameter of the blood supply into the brain will be changes in the pH. So when you have increased CO2 levels, you increase the concentration of hydrogen ions. This will cause vasodilation. And when you have hypocapnia, like when someone is hyperventilating, when someone has uh, this mental situation, the person gets scared or get emotional, start hyperventilating, you reduce your CO2 levels. So that will stimulate a raise in the pH or decrease in the hydrogen levels, and stimulate the vasoconstriction of the blood vessels in the heart, in the brain. Now, within the lungs, we have low blood pulmonary pressure. It usually fluctuates between 25 during systole and 10 millimeters of mercury during diastole. So the blood flow is much lower because you need to have time for exchanging oxygen for CO2. And the oncotic pressure, or the pressure that moves blood in fluids into the blood, it is higher, and the pulmonary capillaries absorb fluid with almost no filtration. And this will prevent the fluid from accumulating within the chambers where gas exchange happens, because these chambers, which are known as the alveoli, they need to be filled with air and not fluid. And the lungs are very responsive to hypoxia. When someone has hypoxia or low levels of oxygen, your pulmonary arteries will constrict, and this will redirect the blood flow into an area where you have more ventilation, or where you have more oxygenation. So this is the anatomy of the pulmonary circuit. So remember, everything starts here at the right ventricle. So the right ventricle will pump the blood into the pulmonary trunk, and then the pulmonary trunk will divide into the left and right pulmonary arteries, and then the pulmonary arteries will form different branches like the inferior lower arteries, superior lower arteries, and then from there you will form more tinier branches that ultimately will form capillaries around the alveoli, and then you will have oxygenation of the blood, and the blood will return using these pulmonary veins from each side into the left atrium. So once the left atrium receives oxygenated blood, the blood can be pumped into the left ventricle, and then the left ventricle can pump the blood into the systemic circuit using the aorta. And this is how the capillary beds look in the deep part of the lung. So if you magnify this part in here, you can see these chambers that are known as the alveoli. So these are alveoli. These are filled with air, and they form sacs like these ones. So this is an opening of the alveoli, or alveolar sacs. And then in here you have these tiny branches, the capillaries from the pulmonary artery, and then they connect into these alveolar capillaries from the pulmonary veins. So you have gas exchange in here. So once you oxygenate your blood, the blue blood, CO2 rich blood, you will convert it into oxygenated blood, or red, and then you return it into the heart. So this is an overview of the major systemic arteries. So in here we have the aortic arch that is going to give these branches that goes into the arms, and then into the head and the neck, and then this aortic arch is going to go down posteriorly in the thoracic cavity, forming what we call the descending thoracic aorta. Is called descending because it goes down, and then it enters into the abdominal cavity, this descending aorta, piercing the diaphragm, and then it will be converted into abdominal aorta. So after that, this is going to split or bifurcate into these arteries, which are called the iliac, and then they will form the different blood vessels of the legs. And when the abdominal aorta is located within the abdominal cavity, will provide several branches to provide blood supply to the different organs in the abdominal cavity, and similarly is going to happen within the thoracic cavity. It will provide all the branches for the thoracic organs and tissues. Some of these arteries within the systemic circuit, we will use them as arterial pressure points. So that's where we can measure the pulse pressure, or the pulse actually. So the most common type of artery that we use to measure the pulse will be the radial artery. Here just above the wrist on the radial side, the side of the pollex. And then we can use in the neck the common carotid artery, in the face the facial artery, just a little bit above and superior to the or a little bit anterior to the mandibular angle. We can use here in the temple the superior temporal artery. The brachial artery can be used here in the antecubital area, femoral artery here in the groin, the popliteal area behind the knee, posterior tibial artery behind the medial malleolus, or the dorsal pedal on the dorsum of the foot. The pulse will vary according, of course, to the heart rate. If you're a young person who doesn't have high blood pressure, you can have a pulse of 60, 65, up to 80, and you will measure it by just pressing with your index and your middle finger the skin above the or on the surface of where these arteries are located. Okay, now let's talk about the branches of the aorta and in general the blood vessels. So the naming. So the naming of the blood vessels usually corresponds to an area of the body or an organ that they're going to supply. And arteries, they have similar names to the veins, and they usually are running together, arteries and veins, with few exceptions. Okay, so we will talk about these few exceptions. So the ascending aorta will be the first part of the aorta that exits the left ventricle, and the branches of the ascending aorta on the right and the left are going to be the right and left the coronary arteries. These coronary arteries are going to supply the heart. Now, as the aorta is going up, it's going to form an arc or arch, and this is going to be called aortic arch. Now, the aortic arch is going to give three branches. It's going to give the brachiocephalic branch, the first branch of the aortic arch, and this brachiocephalic artery is going to form two branches. It's going to form the right common carotid that is going to provide blood supply to the right side of the head and the brain, and the right subclavian, which is going to provide blood supply to the right shoulder and the right arm. Now, the second branch of the aortic arch is going to be the left common carotid. This is going to provide blood supply to the left side of the head and the brain. And the third branch of the aortic arch is going to be the left subclavian, which is going to provide, just as the right subclavian, the shoulder, but in this case on the left side, and the left arm. As the aortic arch is going down, it's going to form the descending aorta. So it's going to be basically the same artery, but it's going to change its name. And as it's going down, this descending aorta is going to give the thoracic aorta above the diaphragm and the abdominal aorta below the diaphragm. In the abdomen, the abdominal aorta is going to give three anterior branches, or branches that goes to the front. So it's going to be the first one, celiac trunk, just below to the diaphragm, then the superior mesenteric and the inferior mesenteric. The celiac trunk is going to provide blood supply to the liver, the spleen, the stomach, the duodenum, and the pancreas. Superior mesenteric is going to provide blood supply to the entire small intestines and also to the first half of the large intestine. And inferior mesenteric is going to provide blood supply to the last half of the large intestine, or to the distal half of the large intestine. Now the lateral branches of the abdominal aorta are going to be the inferior diaphragmatic, the adrenal, which is going to provide blood supply to the adrenal gland, the renal arteries, which are going to provide blood supply to kidneys, gonadal, which are going to provide blood supply to the testicles in males or to the ovaries in females, and the lumbars, which are going to provide blood supply to the lumbar muscles and different structures within that area. So this is to start showing you then this figure, the different branches of the aorta. So here we have the ascending aorta with right and left coronary arteries. Then we have here the aortic arch with the brachiocephalic trunk, which is going to split or bifurcate into the right subclavian and the right common carotid. And then the aortic arch also is going to give rise to this left common carotid and then the left subclavian. And then it's going to go down the aortic arch, changing its name to descending aorta. And then once it pierces the diaphragm and goes down, it's going to be called descending abdominal aorta. The arteries of the head and the neck, they are going to be branches of the common carotids, which runs here on the sides of the trachea. So we have right and left common carotid. And then here, the common carotid is going to bifurcate or branch into the internal carotid, which is going to go through the carotid canal of the temporal bone to provide blood supply into the brain. The external carotid is going to provide blood supply into the face and the scalp, giving all these branches like the maxillary artery, superficial temporal, which is the terminal branch of the external carotid. It's going to give the supraorbital, ophthalmic, the posterior auricular, occipital. So all of these are branches of the external carotid. And some branches of the common carotid will be the superior thyroid artery, which provides blood supply to the thyroid gland, thyrocervical trunk, costocervical trunk, which are actually these two branches of the subclavian, which you can see here. Why this is called subclavian? Because it goes under the clavicle. Sub means under, clavian, clavicle. So one branch of this subclavian is going to be this vertebral artery. This vertebral artery is going to go into this transverse foramina of the cervical vertebrae, and then it will enter into the brain to provide blood supply into the posterior portion of the brain, the vertebral artery. Now, the common carotids then will be running here on the sides of the trachea. So whenever you want to feel the pulse of the common carotids, you have to feel on the sides of the trachea and you feel a strong pulsation. Now, the internal carotid usually develops as we age plaques inside. So this will reduce the blood supply into the brain. And if you have a complete blockage of this internal carotid by plaques and a blood clot, you have a stroke, an ischemic stroke. So on the right and the left side of our neck, we have the vertebral arteries that will merge to form the basilar artery on the pons. And then this basilar artery, together with branches of the internal carotid, will form in the base of the brain a circle of arteries that we know as the circle of Willis. This moves around the pituitary gland and the optic chiasma. And this circle of Willis will include anterior, posterior cerebral arteries and communicating arteries. So here you can see the paired vertebral arteries, how in the pons they merge or anastomose, forming the basilar artery, and they form this this circle of Willis together with branches of the internal carotid. So middle cerebral artery together with this posterior cerebral artery, and then the anterior cerebral artery, they form around the pituitary gland and the optic chiasma, the circle of Willis. This is the inferior view of the brain. And this kind of circle of Willis is important because it will provide some redundant blood flow just in case that one of these arteries is obstructed, the posterior communicating, anterior communicating, or any of these branches. You can still have alternating routes to develop, to provide blood supply to the different tissues of the brain. And then this is the lateral view, or mid sagittal view of the blood supply to the brain, showing you the anterior cerebral artery, the middle cerebral and posterior cerebral artery and its branches. So now for the arteries of the thorax, they provide blood supply to the organs of the thorax or the thoracic wall. So we have the bronchial, esophageal, mediastinal branches, the posterior intercostal, phrenic arteries that are going to provide blood supply to the different tissues and organs. Along with that, we have the internal thoracic, anterior intercostal, and pericardiophrenec that are branches of the subclavian artery, not the thoracic aorta. So you can see here the arteries of the thorax. So this is the descending thoracic aorta, which gives these esophageal arteries to provide blood supply to the esophagus. These posterior intercostal arteries, these bronchial arteries that are going to provide blood supply to the bronchi, inner lungs. And then we have this internal thoracic artery, which is branched, as you can see from this one, which is the subclavian. This is the anterior intercostal arteries, branches of the internal thoracic artery. And then we have this pericardiophrenec, which is going to provide blood supply to the pericardium in the heart and also to the diaphragm. Now that we are here, you can see then the subclavian on the case of the right side, that it is branch of this brachiocephalic trunk that comes from the aortic arch. And the left subclavian is a direct branch of the aortic arch. And then in here we have the left common carotid and the right common carotid in here. Now the subclavian, once it reaches the armpit, the axillary area, it will change its name into axillary artery. And as it's going in this direction, the subclavian is going to provide all these branches: thoracoacromial, costocervical trunk, pterocervical trunk, etc. These are the branches of the descending abdominal aorta, the two branches that I told you about. So this is the celiac trunk, superior mesenteric and inferior mesenteric in here. Lateral branches, the inferior phrenic or diaphragmatic, then the adrenal, superior, middle, and inferior, then the renal artery, gonadal, and then the lumbar arteries. And then the abdominal aorta is going to split or bifurcate into the common iliac, and then the common iliac into internal iliac and external iliac. And here we have the median sacral artery. Branches of the celiac trunk, the left gastric in here, a splenic in here, which is going to provide blood supply to the pancreas, and then the left gastromental, short gastric arteries. Then also it gives the common hepatic, which is going to give the hepatic proper, hepatic artery, cystic artery, which is going to provide blood supply to the gallbladder. And then branches of this common hepatic is going to be gastroduodenal artery, which is going to provide blood supply to the duodenum and part of the stomach, right gastric artery, and also the inferior pancreatico-duodenal, which is going to provide blood supply to the pancreas, to the pancreatic head, and also to the duodenum, which is this part. And then in here we have the blood supply to the stomach, which is the right gastric artery, gastroduodenal, right gastromental, left gastromental, short gastric, and left gastric. Branches of the superior and inferior mesenteric arteries. So the superior mesenteric artery, which is this, is going to give all these branches that are the jejunal, the ileal arteries that are going to provide blood supply to these small intestine regions, the jejunum and the ileum. And also is going to provide blood supply to the first half of the large intestine, which is this, through the colic arteries, the superior, the right, the ileocolic, etc. All of these that you can see here. Now here you can see branches of the inferior mesenteric artery, which is this. So it's going to provide all these branches, the left colic, the sigmoid artery, superior rectal, that are going to provide blood supply to the last half or distal half of the large intestines, which is this. Now let's talk about the arteries of the upper limb. So we have first the subclavian that goes between the clavicle and the first rib. Once it passes the first rib and reaches the axillary area, it's going to change into axillary. And then the axillary, once it reaches the arm, is going to be change its name into brachial. And then below the elbow, this brachial is going to change its name because it's going to bifurcate into two, into the radial if it's go lateral, and into ulnar if it's medial. And then the brachial artery is the one that we use to detect the blood pressure, and the radial artery we use it for pulse detection. So here we have subclavian. It changes its name in the armpit into axillary, and then when it reaches the arm, into brachial. And we have deep brachial and superficial brachial, and it gives these collaterals in the shoulder that are known as circumflex humeral, or here in the elbow as radial collateral. And then in here, the brachial splits into the radial on the lateral side and into ulnar in the medial side. And of course, the brachial will provide blood supply into the arm, and then the radial into the radial side of the forearm, and the ulnar into the ulnar side of the forearm. Now, at the area below the wrist, in the palm, we will have the deep palmar and the superficial palmar arches that are going to anastomose the radial and the ulnar arteries. And then as these arteries split into smaller arteries, they're going to go on the sides of the fingers, making the digital arteries. Now let's talk about the formation of the lower limb arteries. So the abdominal artery, aortic artery, is going to split into the common iliac first, and then into external and internal iliac. The internal iliac is going to provide blood supply to the tissues within the pelvis, and the external iliac, this is the other key point that you need to know, that the external iliac bifurcates into femoral and deep femoral arteries. And then the femoral and the deep femoral will provide blood supply into the thigh, and on the knee, the femoral artery is going to change its name into popliteal, and then the popliteal below the knee is going to form the tibial and fibular arteries. And then below the ankle, these arteries are going to provide blood supply to the foot, and the tibial and the fibular, of course, they are going to provide blood supply into the leg. So here we have the aorta, which bifurcates into the common iliac, and then in here it gives the common iliac these branches, the internal that goes deep, and then the external iliac that goes superficial. And then just below the inguinal ligament, the external iliac bifurcates into the femoral and deep femoral artery. The deep femoral artery follows the femur, and then the femoral artery just in the posterior area of the knee will form the popliteal, and then the popliteal is going to bifurcate into anterior tibial and then into posterior tibial and fibular. And then here within the dorsum of the foot, we will have these arches, the arcuate arch and the deep plantar arch. And as these arteries go into the fingers, they will form the digital arteries, just similar as to the digital arteries that we have in our fingers. So this will be the overview of the major systemic veins. As I said before, these veins, they have a similar name as the arteries with few exceptions. So we don't have these common carotid veins. Instead, we have external and internal jugular veins. The internal jugular vein runs here on the sides of the trachea, while the external jugular vein runs superficial to the sternocleidomastoid muscle. Also, we have dural sinuses, which drains the vein from the circle of Willis. So we don't have dural sinuses for arteries, only for veins. And then we have brachiocephalic veins, which are the equivalent to the brachiocephalic arteries. We have subclavian veins. We have axillary veins. And here within the arm, we have cephalic vein that runs lateral and the basilic vein which runs medially towards draining the blood into the axillary veins. But we don't have cephalic artery or basilic artery, only the veins. Now, here we have in the thorax superior and inferior vena cava that drains into the right atrium. We don't have superior and inferior arteries, vena cava arteries, only the veins. And then here in the forearm, we have radial veins, ulnar veins, we have venous palmar arches, we have the brachial veins, similar as to what we have for the arteries in the arm. And then here in the abdominal area, the inferior vena cava drains the blood from anything below the diaphragm. And anything above the diaphragm is drained by the superior vena cava. And we have the renal veins that drains into the vena cava. We have the gonadal veins that can drain into the vena cava or into the renal vein. We also have adrenal veins that are not shown in here. And then we have the common iliac veins, the internal iliac, the external iliac. We have the femoral veins. We have the deep and the femoral veins, which are basically the same as the arteries. Now, we have also popliteal veins behind the knees, similar as for the popliteal arteries, but we have two largest in the leg. We have two largest arteries. We have the greater saphenous, which runs here medially. As you can see, this is the largest vein that we have. And it can be seen better in a thin young man. So this is the great saphenous vein, which is the vein that actually is used to make coronary bypass. And then we have the small saphenous vein, which is this, which runs laterally in the leg. So we don't have small or great saphenous arteries. We only have small and great saphenous veins. And then here we have the anterior tibial veins, posterior tibial veins, and plantar venous arches or dorsal venous arches, similarly as for the arteries. So here is the mid-sagittal view of the dural sinuses and other sinuses like sigmoid sinus, transverse sinuses, and all of them, they drain into the internal jugular. So the internal jugular runs here on the sides of the trachea together with the common carotid and with the vagus nerve. And this internal jugular is one of the exceptions for the veins that carry high pressure. So this one has high pressure because it drains a lot of blood supply from the brain. And then here's the inferior view of the dural sinuses. So all of these sinuses, they confluent or they merge into this straight sinus, and then this uh, straight sinus will drain into the transverse sinus and then into the sigmoid and then into the internal jugular vein. These are the veins of the face and the neck. So here we have superior ophthalmic facial vein. Here we have the superficial temporal occipital veins, and they drain into these external jugular and internal jugular veins. And then this vein, the external jugular vein and the internal jugular vein, they can drain into the subclavian, and then together the internal jugular vein and the subclavian will merge and will form the brachiocephalic vein. And here we have the axillary vein draining blood into the subclavian. Veins of the abdominal and pelvic region. So here we have the internal and external iliac. They merge or anastomose to form the common iliac. The two common iliacs, the right and the left, they merge or anastomose to form the inferior vena cava. And lumbar arteries, the gonadal arteries, renal arteries, the adrenal arteries, the inferior diaphragmatic or inferior phrenic, and the hepatic veins, they drain into the superior vena cava. Sorry, inferior vena cava. So this is the tributaries of the inferior vena cava. When you hear the word tributary, that means that it brings blood into, in the terms of the blood vessels. It brings blood into, so it drains into. So here are the superior and inferior mesenteric veins that drains the blood that correspond to each of them, similar as to the veins from the the arteries of the superior mesenteric branches. And then here we have the hepatic portal system. So the hepatic portal system is made out of all these branches: the left gastric, the pancreatic, the splenic, superior mesenteric, that together with the hepatic portal vein drain into the blood, and they absorb nutrient-rich blood that it will reach the liver so that the liver can process these nutrients. So the hepatic portal vein is very important. This is another key point because it will deliver nutrient-rich blood into the liver. And when you have obstruction of this hepatic portal circulation, you can increase the blood pressure to back up into the hepatic portal system. And when you have this portal hypertension or increased pressure in the hepatic circulation, you have escape of fluid into the abdominal cavity. And causes for this hepatic portal hypertension is having liver cirrhosis or thickening of the tissue of the liver due to alcoholism. And this will cause the accumulation of fluid within the abdomen, which is called ascites. And as you can see here, this is a huge amount of accumulation of fluid or ascites. So veins of the upper limb, we have superficial and deep. The ones in blue are the superficial, the ones in deep are in purple. So here we have the ulnar and the radial veins. They drain into the median cubital vein. This median cubital vein is the one that it is used to withdraw blood samples. And then you have here the brachial veins that drains into the axillary, which drains into the subclavian. And then we have this basilic artery that drains into the brachial, and then we have this cephalic that goes and drains into the axillary. And then this will drain into the subclavian, and together the subclavian and the external jugular will form the brachiocephalic vein, which drains into the superior vena cava. So for the veins of the lower limb, so you have the dorsal venous arches that drains into the anterior and the small saphenous vein together with this, which is the posterior tibial. And then they will drain into the popliteal. The popliteal will drain into the femoral and the femoral. And then the great saphenous vein will drain directly into the femoral. And then this femoral is going to drain to the external the external iliac, and then the internal iliac is going to join the external iliac to form the common iliac. And both the right and the left common iliac will merge or anastomose to form the inferior vena cava. Okay, so this is the end of this video lecture. Please email me with any questions. For some of you, have a good day or have a good night. Bye-bye.